Hey mamas, it's your CajunStork here. Believe it or not, in midwifery, the word interventions is not necessarily a naughty word. There are times in pregnancy that midwives would actually recommend interventions to your birth experience, and I'm going to talk about a couple of those today and why we might recommend them. But before I begin, my name is Midwife Kyra, and I believe in truly natural birth because I know that it makes for better birth experiences. Consider subscribing to my channel, and don't forget to get your copy of my birth packing and supply list in the comments below. Although midwives are typically high touch and low technology, meaning we approach birth with our hands on and most of the time interventions off, there are times in pregnancy and birth that interventions might be necessary. One of those times is the instance of fetal monitoring. Most midwives practice intermittent monitoring, which means instead of strapping you down to monitors, we would be listening to your baby's heartbeat with a Doppler before, during, and after a contraction or two every 30 minutes, typically in active labor. However, there are situations where continuous monitoring may be necessary, in which case, at least in my practice as a midwife, I would be transferring you over to the hospital for that type of monitoring for your baby. You've probably heard the word decels. This is times that your baby's heart rate kind of decreases. But also, if your baby's just kind of acting up, has a high heart rate or a low heart rate or just some abnormal variations, there are times that midwives would recommend continuous monitoring for the safety of your baby. Another intervention that most people don't picture when they think of midwives is coached pushing. Now, you know CoachPushing, we've all seen it on the movies where everyone counts to 10 in the room, mom grabs her knee, she pulls back while she's laying on her back, and she pushes her baby for 10 seconds on 3 separate pushes. Typically, in a normal unmedicated birth, particularly at the birth center, moms lead pushing. So just because she's complete or 10 centimeters dilated does not mean she's necessarily ready to start pushing her baby out. And even when she is pushing, as long as everything's well, we let mom do hands-off pushing in whatever position she wants, however she wants to do it. However, there are times that coach pushing can be very helpful in a birth. One of those experiences would be if mom is, for example, a first-time mom. She's getting really exhausted and it's time to push out her baby. Sometimes coach pushing is an intervention that we can use in situations like this that can help mom deliver her baby out of hospital as she was planning to do. So although coach pushing is definitely not our go-to, it is a tool in our toolbox that we like to use if it's necessary. Another one of those tools, speaking of tools, is Arom, Artificial Rupturing of Membranes, or you probably better know it as breaking your water. Most midwives, if not all of us, are pretty hands-off when it comes to breaking your water. In fact, it's typically a goal of ours to deliver your baby. It's called on call, which means in the sack. And it's actually really neat. We had 3 of them this year. It's considered good luck for life in most cultures. However, there are times in a birth experience that Arom, or us breaking your water, may actually be beneficial to your birth. And honestly, the details of these options they're extensive. There's so many reasons why we might need to do this. Let's talk about some reasons we would not need to do this so you don't get bullied into it at your next birth experience. We don't need to break your water to kickstart labor just because you're 39 or 40 weeks pregnant. Now, it is a tool we can use to induce labor, whether you're at the hospital or out of the hospital, but we should never break someone's water simply because they're 39 or 40 weeks pregnant. You definitely don't want an Arom if your baby is not at 0 station, which means the depth of the baby in the pelvis. So when you're getting a vaginal exam before considering Arom, be sure to ask your provider, what station is my baby at? If the answer is not 0, there's a risk of something called cord prolapse, which is very dangerous to your baby, and you would not want to generally consider that as an option in your birth experience. It's just the risks are just too high. If you have questions, you can post them in the comments below and I'll see if I can answer them. Another intervention that midwives don't like to use, but it is a tool in our toolbox, is Enemas. Now, back in the day, they used to put women in the hospital, shave their vaginas, give them an enema and often break their water as well, to get them to give birth. And because of that, childbirth education has now really harped on advising against enemas in birth. However, in the rare instance that a mother would be severely constipated in her pregnancy, or particularly if she's going into labor and her bowels aren't moving, an enema can be really helpful to empty out the bowels in preparation for the birth. Now, I would definitely not recommend this as a routine intervention, but there are circumstances that an enema could be beneficial. So be sure to talk to your healthcare provider about this option if you think you're one of those cases. And the last one I'm going to touch on today is postpartum Pitocin. I'm talking about something a little bit more detailed called active management of the third stage of labor, which means a shot of Pitocin in your thigh or in your IV immediately following the birth of the baby's shoulders. This is not a routine part of midwifery care. In fact, if anything, we really try to use the hormone oxytocin, which is the natural version of the synthetic hormone Pitocin, to stop bleeding after the birth and get your placenta out. So if we have good birth etiquette, then your placenta tends to deliver a lot more smoothly. So good birth etiquette, it means a quiet room, unrushed and unhurried, letting mom and dad and baby soak up those first few moments skin to skin, and letting those love hormones work. It means dim lights and quiet voices and respect for the newborn and the family, and letting them be all in their hormones those first few moments after birth. This is nature's version of active management of the third stage. But sadly, in most hospital environments, this is just not the case. There's people coming in and out the room, the doctor's delivering the placenta, and the risk of bleeding does increase. So active management of the third stage actually decreases the risk of bleeding by about 50%. But in most cases, this is not an intervention we would use routinely, but it is an intervention we have in our back pocket if it's necessary. So there's many other interventions that we would have in our back pockets, but these are just the most common 5 that I think you would find your midwife would recommend if it were necessary. If you have any questions, post them in the comments below. Otherwise, I'll see you in one of the videos up here on the screen. Thanks for watching this Midwife Monday. Bye-bye.